Good evening, everybody. I'm Professor Samah Salama, Professor of Ops and Gynae in the National Research Center and member of the Egyptian Representative Committee. I would like to welcome all of you and thank all the doctors who is attending this webinar for sparing their time to attend with us. I would like to welcome our distinguished speakers, Dr. Fatma Al-Hadhoud from Kuwait, Dr. Mohammed Gamal from Germany, and Dr. Ahmed Zibda from Jordan. This webinar actually is our number 18 webinar run through the Egyptian Representative Committee. We started this webinar since the year of Corona in 2020. The Egyptian Representative Committee is the formal body representing the Royal College here in Egypt, and we do our job in collaboration with the International Representative Committee of the MENA region. Today, the webinar will consist of 3 presentations. Each presentation will be 20 minutes, and after this, we'll have 5 to 10 minutes for questions and answers. You can send any question to me on the chat room, and we'll answer the question to the speaker after finishing the presentation. The Egyptian Representative Committee is formed of 8 members, and the chairperson is Professor Yasser Abu Talib, Professor of Ops and Gynae in Ain Shams University. A big welcome to Professor Yasser Abu Talib, who will give us a welcome opening note. Dr. Yasser, would you please start?
Okay, that's fine. So to start with, I would like to welcome everyone here. Thank you very much to join our meeting. It's the 3rd or the 4th one. We decided actually to have a series of webinar, which is international one. However, recently we started to have a sort of collaboration with members of the International Representative Committee in the MENA region. We conducted actually 3 webinars, and this is the 4th one. And I'm very happy actually to join Jordan and Kuwait as well, to have some sort of collaboration in our future activity. To start with, I would like to announce the next webinar, where we are going to discuss a very important critical subject, which is the new one. It's artificial intelligence in the field of obstetrics and gynecology, and it will be a month later from now. And we are inviting one of our colleagues from America and another one from England, and the head of the Society of the International Intelligence in the MENA region, just to speak and discuss the issue of artificial intelligence. I hope today to enjoy our presentation. We will try to be as concise as we can, as we have 3 countries, Jordan, Germany, and as well Kuwait and Egypt as well, with a sort of communication and conducting sessions regarding to a very critical subject, endometriosis. So I'd like just to thank the International Representative Committee in Jordan, Dr. Mazen and Dr. Fatma as well in Kuwait, Dr. Mohammed in Germany, and we are going to start the webinar within a minute. However, I would like just to announce to make a very important announcement. So, Mr. Ibrahim, would you mind to start my first slide? Okay, so as regards to our international conference, which will be held December, it will be between 11 and 12 December. It will be in Triumph Luxury Hotel, and we are going to host a very important subjects. However, I would like to announce the names of the eminent personnel and professor that we are going to join our meeting. So it's just a gentle invitation and a kind invitation for everyone. If you are interested in our conference, which will be great, so try to contact us to reserve your place. Next slide. It's a great pleasure actually to invite our eminent professor, Dr. Mohammed Abul Ghar. He is going to present a very critical, important presentation. He's the honorary guest of our meeting. However, the honorary president of our meeting will be our great professor, Professor Gamal Abu Sroor, who was the head of many societies before, and I think everyone knows him. and as well Professor Dr. Hassan Salam, who is an eminent figure in many subjects as well. So it's our pleasure actually to invite three of them to have great presentation. I am the chair of the committee, and I would like just to welcome as well Dr. Wafa Benyamin, who is designing and doing her best to make the conference successful. Next slide, please. What's good as well, we are representing the Royal College, as you all know, so it gives me a great pleasure to announce that Dr. Rani, the head of the Royal College back in England, will be here, besides Professor Dr. Hassan Shahata, who is Professor Dr. Hassan Shahata, who will join us. He is the Vice President of the international things related to the college. He will be there, Dr. Asma as well, and Kate Lancaster, who is the CEO of the Royal College. As well, Professor Dr. Sharif, who is Sharif Al-Fatah, who is responsible for the MENA region activity, will be there. Will be there. Okay, so next slide, please. It's my pleasure as well to announce the heads of the International Representative Committee in Saudi, Dr. Amina, Dr. Taghlid from Iraq, Dr. Abir from Kuwait, Dr. Mazen from Jordan, and Dr. Rasman from Qatar. It's our pleasure to join us as well. Next slide. Ibrahim, next slide, please. And lastly, I would like just to announce our, besides our conference, I would like to announce our meetings and workshops. 3 workshops will be held between 9th and 10th of December. It's the TLH, total laparoscopic hysterectomy, pelvic floor surgery, including everything regarding to vaginal hysterectomy and incontinence as well, and advanced fetal medicine, including the intervention techniques. It will all the 3 will be held 9th and 10th of December. And beside that, 13th, after finishing the conference, we will have 2 courses, colposcopy and oncology conference, and as well as advanced assisted reproductive course. So thank you very much to join us, and looking forward to see all of you joining our conference December. And if you want to contact me, I will be more than happy personally and through the Egyptian Representative Committee of the Royal College. Thank you very much. And back to Professor Dr. Sameh to start the first presentation. Dr. Sameh, please.
Okay, Dr. Yasser, thank you.
Okay,
so
welcome.
Our first speaker will be Dr. Fatma El-Hadhoud from Kuwait. She's a consultant in obs and gynae and minimal invasive gynecological surgery in the University of Ottawa, Canada. And she's a member of the Society of Endometriosis and Uterine Disorders. She's also a member of the American Association of Gynecological Laparoscopists and International Pelvic Pain Society. Her presentation will be on the updates in endometriosis. Dr. Fatma. Dr. Fatma.
Thanks, Dr. Sameh.
Hello. Would you start, please?
Yes. Thank you. First, I want to thank for the invitations. It was my pleasure to be part of this webinar. I'll be talking about the updates in endometriosis. I'm going to start. First, I want to start my presentation. With the statement from the American Society for Reproductive Medicine Practice Committee that endometriosis should be viewed as a chronic disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoid repeated surgical procedures. I'll be talk about what's new in diagnosis of endometriosis, management, and the risk of endometriosis in the last couple of years regarding this chronic disease. Starting with the diagnosis, still we are facing as a physician a delayment in the diagnosis of endometriosis, reaching 7 to 10 years or more from the initial symptoms till the proper management. According to a retrospective cross-sectional study investigating the prevalence and the therapy in Germany over 2010 to 2019, there was a significant changes in the prevalence and medical therapeutic patterns of endometriosis in 2010 comparing to 2019, reflecting changes in the therapy guidelines and possibly in diagnostic methods. This is what we are going to show in the couple next sliding. The aim is for early detection to reduce the morbidity, the healthcare cost, a productivity decline associated with endometriosis. So early detection and management of the condition are crucial, along with improving the awareness about the disease. There should be awareness not only to the population, but also to the physician about this disease as an early detection to avoid the complication. The clinical diagnosis of endometriosis is changing. The problem is before we use laparoscopy for a definitive diagnosing of the disease. Now we are moving more for a combination of patient interview, clinical examination, and imaging for diagnosing a patient with endometriosis. So this modern endometriosis management should be individualized and interdisciplinary integrated approach according to each patient separately. Implementing clinical diagnosis techniques can reduce the delay in the time of diagnosis, bring a rapid relief to affected patient, limit the disease progression, and prevent the sequelae. So according to the modern diagnosis of endometriosis, laparoscopy is no longer the gold standard. It is only recommended if patient has a negative imaging and there is unsuccessful or inappropriate treatment with empirical treatment for endometriosis, what we are going to do coming next slide. Using an ultrasound as an imaging has a high accuracy in the diagnosis of deep and ovarian endometriosis and can replace laparoscopic examinations. I believe Dr. Ibrahim will talk more thoroughly about this, but just to highlight that comparing transvaginal ultrasound with diagnostic laparoscopy has almost the same or no significant difference in sensitivity and specificity in rectocervical, ovarian, and bladder endometriosis. While ultrasound show a higher as a diagnosis in rectosigmoid endometriosis and vaginal endometriosis than laparoscopic route. So ultrasound is a valid tool for diagnosis of endometriosis. So all the international guidelines are moving to use an imaging for diagnosis of severe endometriosis and endometrioma, like the American, the French, Germany and Canada, also the ERC guideline are all moving to use an imaging for diagnosis of endometriosis and recommended to treat and proceed with the management according to imaging. So in 2022 ERC guideline, the use of imaging for diagnosis of endometriosis. So they recommended in women with suspected endometriosis, further diagnostic steps, including imaging, to be considered, or going with the clinical examinations. Clinicians also recommended to use imaging as ultrasound or MRI in the diagnostic workup for endometriosis. I'm going to talk now about the endo test, which is a potential role for microRNA, which is a French innovation. Tests used and represent a major paradigm shift in the clinical practice. This test is not yet validated as a commercial use, but it's a less invasive test using the saliva for detecting a positive endometriotic cases. It's validated with one of large clinical trials used in collaboration with 18 French specialists endometriosis center using 109 different microRNA for analysis to detect endometriosis. It's easy to use, non-invasive, can be giving a clear cutoff of positive and negative result. It's helped with early diagnosis. It can detect all forms of endometriosis. It has a sensitivity more than 95%, a specificity more than 95%, and a diagnostic accuracy of more than 95%. But just to keep in mind, using this test is not a replacement for the imaging. Imaging remains the essential for diagnosis for the lesion, description, mapping, and the classification for the disease. Moving to the management, there is a lot of hormonal option available in the market for treatment of endometriosis. This is as an option for the medical treatment. So management of endometriosis lesion changing now from using a medical treatment to replace surgical option. Treatment of the lesion, it will help to treat the clinical symptoms. Counseling should be completed and transparent with the patient, and the duty of the caring gynecologist is to inform the woman about the pros and cons for each option and support her in the shared decision-making process, taking into considerations the woman's preference and the priority, and also the compliance. So a lot of options to be opted to the patients or women, like combined oral contraceptive, progesterone-only pills, like the famous treatment we are using is the Dynogest, using the hormonal patch, the IUD hormonal system, the Implanon, and GnRH analog injections. Keeping in mind the medical options after a complete interview for the patient, full examinations, and giving the patient a preference for choosing the proper medical treatment. According to the ERC 2022 guideline, endometriosis associated pain can be treated with hormonal therapy. Choosing hormone treatment associated pain should take a shared decision making approach and take into the consideration the following: individual preference, the adverse events of each medication, individual efficacy, and cost and availability. Recurrence after surgery is a challenge in the treatment of endometriosis. We know that the recurrence rate according to the site of endometriosis is higher in deep endometriosis, deep infiltrating endometriosis, and in ovarian endometrioma. Also, reoperation is not recommended regarding patient pursuing fertility future-wise. So a half woman of had an average of 3 operations in a 10 years period, according to the recent data. Also, the chances of pregnancy after reoperation may be substantially lower than after the primary procedure. Keeping all of this in mind, we have to move more about starting the medical treatment as a first-line management before going for surgical treatment, and preserve surgery for non-responsive or with contraindication to use of hormonal therapy. If we're having an endometrioma of more than 3 to 5 centimeters, going through an assisted reproductive technique, and her treating doctor or physician advised to go for surgery for difficulty to go through this assisted reproductive technique cycles due to extensive adhesion, can't reach the ovaries for egg retrieval. Also, if there is a functional organ damage, or when the cyst is rapidly growing, or we suspect an malignancy. So the current management is favoring surgery, and most of well-known centers and physicians prefer to go for surgery as a first option. That should be changed and moved to the more modern management tool and the strategies to afford more long-term medical treatment before going for surgery. I put here a few different scenarios for different cases, depending on who's desiring pregnancy or just to control the symptoms related to endometriosis. We have to keep in mind and educate ourselves as a physician first, then the population, that between gapping of pregnancy, the use of long-term medical treatment is recommended to suppress the disease and keep it under control. So the message is to move more toward the medical treatment before giving the option for surgery as a first line treatment. So this can help in most of the cases before going to surgery. So the long-term medical treatment is help to maintain, restore fertility, alleviate the pain and other symptoms, reduce the number of unnecessary surgery. As we mentioned before, the recurrence, or half of the women are going through 3 or more surgery within a 10-year period, and to prevent future surgery. Also to avoid the recurrence and reduce the lesion size. This is the recommendation from the ERC, the latest ERC guideline to use progesterone, like the Dynogest, or the combined oral contraceptive as a first line treatment for endometriosis before going to surgery. Just to highlight what's new in the market, we are familiar with the GnRH agonist, but now we have the antagonist in the market. In the latest years in the practice, it's more in North American market, which been selling under the name of Elagolex and Rilogolex. They are effective and have an immediate action, and it doesn't cause any initial surge in LH and FSH, and also it's not requiring a 7 to 14 days for LH FSH suppression, and it's available in an oral form. We have the Elagolex, which is been in the market in 2 formula, the 150 milligram, which used once daily for or up to 2 years, or the 200 milligram BD twice daily for 6 months. And this is giving alone without an add-back therapy. Sorry. The Rilogolex is a combination therapy of or like a monotherapy of relugolix with estradiol and norethindrone combinations that can be used directly for 6 months, or we can use the regimen of monotherapy for 3 months followed by a combination therapy for also 3 months of a total of 6-month course. Just to keep in mind that these medications have the same risk of hormonal therapy and regarding the risk of thromboembolic events. Aromatase inhibitors is used also for newly as a treatment option for endometriosis. We have to mention for the patient that this is an off-label use, but it is ineffective in treating endometriotic lesion. It's helped to regulate the local estrogen formation from the endometriotic lesion itself, also inhibiting the estrogen production in the ovary, brain, and periphery. Just to keep in mind, there is 2 formula available in the market, the anastrozole 1 milligram once daily, or letrozole 2.5 milligram daily for a course of 6 months. Using this medication for a 6 months is reasonable to reduce the side effect, as prolonged use can cause bone loss density or a formation of ovarian follicular cyst as treatment. Moving from the medical treatment to the surgical approach with the preserved ovarian reserve. Just to keep in that endometriosis specialist known that using cystectomy for cases of endometrioma with hemostatic agent or suturing is giving a better outcome regarding the ovarian reserve and the AMH level when comparing to using cystectomy with bipolar electrosurgery. I'm not going to talk about the classical treatment for endometrioma surgically, but I'm going just to mention the new techniques that have been used and proven to preserve the ovarian reserve during surgery. Regarding cyst aspiration, it is ineffective for treatment of endometrioma because of high recurrence rate, reaching up to 80 to 100% in 6-month duration. But using a drainage with replacement or placement of oxidized regenerated cellulose under the name of commercially that's Surgicel is a promising technique to preserve the ovarian function with the recurrence rate similar to cystectomy. So if you have a difficulty doing cystectomy for big endometrioma, do drainage and put Surgicel in the ovarian bed, and this will help with preserving the ovarian reserve and decrease the recurrence of cystectomy, especially if the patient going to assisted reproductive technique. What about the cyst sclerotherapy is another technique used in endometrioma therapy. Consists with injecting a sclerosing agent like ethanol, tetracycline, or methotrexate in the cyst cavity. It will disrupt the epithelial lining, causing inflammation, fibrosis, and ultimately obliterating the cyst. It can be performed laparoscopically or vaginally. It is less invasive and alternative to cystectomy. Just to show you here how we are performing cyst sclerotherapy. There is some data showed that using a sclerotherapy may reduce the reserve and the AMH level, but it's not as comparing with cystectomy. And it helped with reducing the size especially if the patient is moving to an assisted reproductive technique using an IVF after that help with accessing the follicles during the egg retrieval easy. Here we can see after drainage of the or aspirate of the cyst using a direct trocar entry. Now injecting the cyst with sclerosing agent, we can see the distension of the cyst wall with the agent and keeping the agent for a couple of minutes up to 10-15 minutes. That help with inflammation and fibrosis of the lining of the cyst, and then after drainage of the sclerosing agent. Moving for the last part of my presentation, the risk of endometriosis related to ovarian cancer. Just to keep in mind that endometriosis, according to the old data, that is increase the risk of ovarian cancer, but as 2 or 3-fold. But the new data showed that endometriosis of any lesion can cause a 4-fold increase of ovarian cancer, and the deeply infiltrating endometrioma also showed an increase of 10-fold risk of ovarian cancer. But to keep in mind that it doesn't mean that we have to consider endometriosis as a pre-malignant lesion, and surveillance for ovarian cancer is not recommended. The use of oral contraceptive pills, it's shown by latest data, it's decreased the risk of ovarian cancer with endometriosis. Also, cystectomy can decrease the risk of ovarian cancer related to endometriosis. Thank you, and this is the end of my presentation.
Thank you, Dr. Fatma, for this very nice presentation, and we have some questions. So our first question is, one of the doctors attending is asking you, he had a patient with 3 years of infertility. He's not mentioning if it's a primary or secondary infertility. She is 25 years, and she has a chocolate cyst 3 centimeters, and she has a polycystic ovary. And she had a previous ovarian cystectomy. So what do you think about the management?
So patient, what I can recall, she's seeking
She's
pregnancy.
25 years old, and she has a history of 3 years of infertility. He's not mentioning if it's a primary or secondary. And she has a chocolate cyst, 3 centimeters, and she also has a polycystic ovary. Okay, and she had a previous ovarian cystectomy.
Yeah. So in these cases, if she's young with an endometrioma of 3 centimeters, they didn't mention if it is bilateral or on one side, and if the cystectomy was done on the same ovary or the other ovary. An AMH level is helpful, and I think in these patients, if she's desiring an immediate pregnancy, should be referred for a reproductive endocrinology specialist to go for assisted reproductive technique that will help with getting her pregnant.
Okay, so a repeated question: how long we can give the Dynogest? I mean, the maximum duration of treatment.
According to the recent data, we can give up to 3 years continuously, with monitoring the bone mass density of the patient. Because according to the East Asia's data from Korea and Japan, which use the Dynogest for the largest or the longest period of duration of the medication, up to 7 and 10 years, they show that patients with Dynogest more than 3 years can have or experience some bone loss. So we can give a break for 3 to 6 months with monitoring the patient symptoms, and restart again if the bone mass density within the normal or just under within the normal range.
Okay, another question, what is the value of early detection of endometriosis if the patient is not complaining? So if you have a patient is not complaining, what's the value of early detecting endometriosis?
This is the dangerous group of endometriotic patients, actually the asymptomatic patient. Usually these patients will present if they have a deep or advanced endometriosis and they are asymptomatic. They will have like an organ damage failure. They will present late with bowel obstruction or compression of the ureter or with renal impairment because they are not feeling the pain or the symptoms of the endometriosis, and they are showing with advanced or a late sequelae. It's not all of the patients, but some of the patients, they will present first time with, and I've been seeing this with bowel obstruction or with renal impairment, with the long compression on the ureter and backflow of the backflow on the kidneys, and they lost their kidneys actually. So we'll try our best to try to detect patient with endometriosis, even if not starting a treatment or medical therapy with asymptomatic patient, but at least to keep monitoring these patients 6 months or 12 months apart to see if there is any progressive in the disease.
Okay, so many doctors are asking about the endo test. So how expensive it is, and is it a valid test or still under research? And is it available in Kuwait?
I know it's the new innovation from the French committee. I'm interested in this test actually, but still, according to their data and the publications, it's a high sensitive and specific, and it's giving a negative and positive result directly. Actually, the cost, I'm not sure about it. Still, it's not available in the market for commercial. It's still used for study reason, but hopefully it will be in the market soon, so we can be used and helpful for diagnosis of.
So one of the doctors saying it's present in the Saudi Arabia. They do this test.
I'm not sure about it, but if it's available in Saudi Arabia, it's perfect.
Okay, so the last question is a doctor is asking if she's using a medical treatment, is it better to use it continuously or in interrupted manner?
Sorry again, Dr. Sameh.
So regarding the medical treatment, one of the doctors is asking, should she use medical hormonal treatment continuously or interrupted?
No, continuously.
Continuously.
But also we have to tailor the management according to the patient preference. Mm-hmm. We can use it as continuously with interrupted every 3 to 6 months to have a withdrawal bleeding 3 or 4 times a year. This is according to the patient preference, but I prefer the back-to-back continuous hormonal treatment with amenorrhea to control the symptoms.
Okay, so this question is very important. Would you recommend surgery first or assisted reproductive technique in patients with deep endometriosis and infertility, and why? What's your opinion on ERT in the presence of stage 4 endometriosis? I think this is
a big question. It needs a full lecture to talk about it.
Yes, it's a very difficult one.
It depends on the patient presentation and what kind of deep endometriosis she has. If her endometriosis is just in the ovary, or it's involved the recto-vaginal area, or it's obliterate the posterior cul-de-sac, or it's involved there her tubes. So all these I need a data and a full mapping of the patient condition before giving her the option to go for surgical option as a first line. I'm not talking about organ failure, because if there is an organ damage or failure, we have to go directly for surgery. But I'm talking about a fertility patient that she's seeking pregnancy with an advanced or deep infiltrating endometriosis. So usually in these cases, I will refer the patient for reproductive endocrine physician and infertility. I'll take their opinion. We'll do an AMH level as a baseline. We'll see if we can collect and freeze and go for the surgery. And after the surgery, the patient will go back to embryo transfer. It will be one of the best scenario, but sometimes the reproductive endocrinologist specialist will refer the patient back that there is difficulty to reach the ovary or the eggs to retrieve before during like the egg retrieval. So we have to go for surgery first, then refer her back to an IVF. So there is no one answer.
Yes.
Each case is different, and we have to have a multidisciplinary integrated, even with the radiologist, to give a correct mapping for the disease before going for the surgery or going for IVF first.
We're having many other questions, but I think we're running out of time, so we can postpone those questions to the end. So thank you, Dr. Fatma, for this very nice presentation. Thank you so much.
Thank you. Welcome. I'll be waiting for the end.
So our next speaker will be Dr. Muhammad Gamal Ibrahim. He's an Egyptian consultant doing an extraordinary job in Germany. He's a consultant of reproductive medicine and medical director of Certified Infertility and Endometriosis Center, Team Kinderwunsch Oldenburg, if I'm pronouncing right, in Germany. He's an ERC-RCOG Certified European Fellow of Reproductive Medicine. His presentation will be on the proper diagnosis of endometriosis using ultrasound and effective patient counseling regarding reproductive outcomes. I think he will answer the questions of left from the previous presentation. Welcome, Dr. Muhammad.
Oh, thanks a lot, Dr. Sameh. And first, I want to extend my great thank you for Professor Yasser and for you for inviting me and letting me to have the opportunity to give a talk today about endometriosis. It's a very hot topic. There is a lot of debate about endometriosis, a lot of congress, a lot of meeting, a lot of patients as well. So many thanks for your invitation, and I am really pleased to have this eminent speaker, and many thanks for Dr. Fatma. I think she had done a very good job and a very soft, good introduction for my lecture, so making my task much more easier. So thank you a lot, Dr. Fatma. So to my person, I am Muhammad Gamal Ibrahim. I am Egyptian. I have done my residency in OB-GYN in Zagreb University in Egypt. And I was also there a specialist of gynecology. And I have started to learn the IVF, the first steps I have done it in Egypt. I have been now settled in Germany for about 14 years. I am a senior consultant of reproductive medicine and specialize in endometriosis. I have something to say that I am not doing any laparoscopy anymore. So I am a pure IVF consultant or consultant of reproductive medicine, as well as I am a certified European Fellow of reproductive medicine from the ERC-RCOG. So actually, this is a very hot topic. And as Dr. Fatma introduced us in her nice lecture about the changes in the guidelines in the last years regarding the diagnosis of endometriosis. So the first 2014 was the guidelines recommending using the laparoscopy as the gold standard for diagnostic of endometriosis. But coming up with the latest guidelines in 2022, we have a game changer, and this is the high resolution ultrasound machine, which I assume every gynecologist attending this webinar is going to have it or is already having it. So I try to make the best of our resources that we have already in our outpatient, in our clinic, in IVF centers. So using this ultrasound machine for effective diagnosis of endometriosis, and how can we interpret these ultrasound findings to help us as IVF specialists or maybe a gynecologist to properly and effectively counsel patients about their reproductive outcome. So let's start with, first of all, I hope you can see my screen. This is my conflicts of interest, and I go through my agenda today. So starting with the going through the prevalence of endometriosis, giving a brief introduction about what's called endometriosis fertility index, because actually my talk is based on this endometriosis fertility index. Then going through the diagnostic of endometriosis in IVF center, so in outpatient, not in inpatient, without using laparoscopy, and coming to the fourth point to ask or to answer the question of the woman or endometriosis patient, can I get spontaneously pregnant or not, and when to do ART or IVF in endometriosis patient, and summing up with a conclusion. It's actually a big talk. Usually I spend 2 hours to take it, to give it, but I try to concise it for 20 minutes or 30 minutes maximum. Prevalence, I don't have to mention it, but we have already 200 million patients worldwide having endometriosis. Just to compare with diabetes, diabetes is only about 450 million patients are diabetic, and if we are assuming that 50% of them are women, so we have the same prevalence as diabetic, as a chronic disease, and a big chronic disease and a big issue and a big disease affecting a lot of patients. Actually, here in Germany, we have estimated about 40,000 new cases every year. We have a problem with the delayed diagnosis. That's what Dr. Fatma already talked about. So I will jump to the second point and say, okay, how can we counsel our patient? How can we see the endometriosis and counsel our patient, not regarding their pain, but regarding their fertility issue for their reproductive outcome? So just a brief introduction for endometriosis fertility index. It's not a new one. It's first published in 2010 by Adamson from USA. He is an endometriosis surgeon, and he is a well-renowned endometriosis surgeon. He came up to the idea to have a functional classification, or a functional index or functional scoring of endometriosis. Actually, what you see on the slide, this is a 2-part index, the historical factor, and it's very clear to have a historical factor regarding the age of the patient. If the patient is young, she has a better prognosis than the older patient, and the years of infertility, if it's less than 3 years, so has a better prognosis, and if she was previously pregnant, so then she is going to have a better prognosis regarding sort of reproductive outcome. And the second part is relating to the surgical factor, because he based his index on the surgical finding during laparoscopy. So regarding the first one, this is the least function score, so the function of the tube and the ovaries estimated, and if they are both functioning well, so she is going to have best prognosis, and according to the extent of endometriosis during surgery. And the third one is the extent of adhesions during surgery. So if we have a lot of endometriosis, advanced endometriosis with frozen pelvis, then we have the least prognosis. And if there is a tubal functional loss or a loss of the ovarian function, so then we have a big problem with prognosis. So calculating this index from the 3 historical factors and the 3 surgical factors, he can proceed to this plotting, and we can see this curve coming with the score. If you are reaching a high index, so you have a very high spontaneous pregnancy conception probability, reaching up to 80% after 3 years after removing endometriosis. So actually, this is the best prognosis patient, and the least prognosis patient, Those are old patients, have a long time of infertility, having advanced endometriosis, so usually extended endometriosis with frozen pelvis, with maybe compromised tubal function. So they are going to have only about 10% of spontaneous conception rate, even following them up to 36 months, so up to 3 years after following endometriosis surgery. So we can summarize this and make it much more simple in this way, that we say from the hysterical factor and surgical factor, we can divide our patient in 2 groups, 2 randomly organized groups. The first one is the group with good prognosis according to the history. This is the young patient has been pregnant before and a very short duration of infertility. On the other side, so the surgical factor, we can change it today and say, according to sonographic findings, we can say that we have also a good prognosis patient who have still have good tubal and ovarian function. They have some sort of minimal endometriosis and some sort of minimal adhesions. On the other way, we have poor prognosis patient. This is the old patient, hasn't been pregnant before, and with a long duration of infertility. And according to the sonography, we have seen that the tube, the ovary, has been damaged or is damaged with advanced endometriosis and frozen pelvis. And this is what I am trying to convey today in my talk. So to have a classification maybe in mind, you don't have to keep it in mind, so just like scores or index, but roughly speaking, dividing, classifying the patient in a good prognosis group and in poor prognosis patient. Good prognosis patient, they have a favorable outcome or maybe a favorable probability to get pregnant on a natural way, so we can encourage it. And the poor prognosis patient is going to have much more assisted reproductive techniques, so going further for IVF. But still the problem is, how can we diagnose endometriosis in IVF centers, again, without the necessity of a laparoscopy? I think 2 resources we do all have in our clinic. You hear what you ask about, so I'm rushing to the first point. This is the history taking. And if you heard about the dysmenorrhea, dysuria, dyschezia, dyspareunia, and sometimes with atypical pain, and especially in the presence of infertility, we have very highly suggestive symptoms of the presence of endometriosis. So just talking to your patient, you can have the suspicion that she is having endometriosis, so you can go further for the next step, and this is you see what you know. So you have the ultrasound machine, so the transvaginal sonography, and you have to examine your patient in a structured way. According to this endometriosis fertility index, as you see on the right side of your slide, you see the sonographic findings. According to them, we can classify our patient according to the tubal and ovarian function, according to the extent of endometriosis, according to the extent of adhesions, into 2 groups, one with good prognosis and the other one with poor prognosis. So this is what I am going to cover in the next slide. How can we examine the ovarian function using the ultrasound? If you see this ultrasound picture, this is a familiar one to all of you. This is an ovary affected by an endometriotic cyst. It's bigger than 3 centimeters. We see around here and on the outer side, there is still a healthy part of the healthy ovarian tissue. Still some antral follicles are seen. So we can, based on this ultrasound finding, not to just to say you have an endometriotic cyst, but we can classify the patient without the necessity of laparoscopy and say you have a 3rd stage of endometriosis, because big endometrioma get usually 20 points on this Atron classification. And according to the #NCN classification, you have a moderate big endometriotic cyst on the left side. This is O2 on the left side. And according to the percent of healthy remaining ovary, this is almost roughly saying it's a 50% remaining healthy ovary. So you have a moderate loss of function of the ovary. This is according to this endometriosis function index. We still have to count the antral follicle count to have a very clear idea about the ovarian function. Clear, we can add to it to the AMH, but I am referring to the examination carried out in the outpatient clinic without necessity of any further investigation. How can we maximum use of our resources? So again, we see here a video of endometriotic patient. So I think, yes, this one. So this is a very big endometrioma, about 4 centimeters, and you can't see any remaining healthy ovarian tissue. So the percentage of healthy remaining ovary is 0, and the antral follicle count is accordingly 0. So she has a much more compromised ovarian function. This is the ovarian function, the ovarian reserve, because on this side you have almost loss of function of the ovary. It's not functioning ovary on this side. So depending on this ultrasound picture, I have diagnosed the endometriosis. This is what we can summarize for the first part. Presence of endometrioma, especially if it's a big one. According to the ERC, we can confirm with the presence of these ultrasound findings, the presence of endometriosis without the necessity of laparoscopy. We can even classify the endometriosis according to the ASRAM stage, according to the NCCN classification, also without the necessity of using a laparoscopy or doing a laparoscopy. And we can assess the ovarian function so that we can calculate it at the end according to the endometriosis fertility index, and the presence of a big endometriotic cyst indicate at least a moderate loss of function of the ovary, sometimes a complete loss of function of the ovary, as you have seen in the last patient. So coming to the second point, we examined the ovarian function. We have seen the endometriosis and how it's compromised the ovarian function. We can test the tubal function. And this is the second point in this endometriosis fertility index. So the tubal function, actually, that is what I am doing also in the clinic using the HIFU-Z, so the hysterosalpingography, or using the foam salpingography, using the ultrasound. You see that the tubes here are patent. So you have patent tubes. If you are suspecting this endometriosis, having endometriosis, so usually it's a first stage as a minimal stage of endometriosis, but still you have a patent functioning tube so that you can see the function or the tubal function is still preserved in this patient. Again, I'm not going through this classification of ASRAM and NCCN, but again, you can classify this patient without doing a laparoscopy. Here again, so live scene video. You can see this is a big hydrosalpinx. So we can say this is a complete loss of the tubal function on this side because it's obstructed the tube on this side. And hydrosalpinx is usually classifies the endometriosis patient in the third stage because it's acquires 16 points. So we have a third stage endometriosis, just seeing the hydrosalpinx and an endometriosis patient, and you have a complete loss of function of this tube on this side. So there is a loss of function of the tube on this side. So that we can return back again and say, okay, from 2 factors, the ovarian function and the tubal function, we can see if the ovary is still functioning well, and if the tube is still patent, it's still functioning for the spontaneous pregnancy. So coming to the third point, so the extent of endometriosis, and this is what actually changed in the last years, because actually we can see even the peritoneal endometriosis. This is a real case from our clinic I have examined. This is a lesion. You can see an endometriosis nodule very close to the bladder, very close to the intestine, and you can see the lesion, this nodule, very close also to the ovary, highly vascularized. Using the color flow Doppler in it, you can measure it. It's about 1 centimeter or 1.5 centimeter big, and this is a kind of peritoneal endometriosis. You have seen it again without the necessity of laparoscopy, and you can stage the patient as a first stage of ASRAM classification, and according to the NCCN classification, this is a P1. Then again, another example of a peritoneal endometriosis. This is an ovary. This is post-ovulatory phase. You can see the corpus luteum here, and then beneath the ovary, you see here a compressed endometriotic lesion in the peritoneum. This is the ultrasound scan, a transvaginal. This is the peritoneal covering, and it's really thickened on this area. And using with a color flow Doppler, you are going to see the hypervascularity on this area. This is very typical for peritoneal endometriosis. So I think it's coming to the updates of Dr. Fatma, we can say we can see the peritoneal endometriosis even with ultrasonography. Here again, another kind of endometriosis. This is not the peritoneal one, but this is the deep infiltrating endometriosis, and this is a bladder endometriosis. As you see, this is an anti-flected uterus, and in front there is the bladder wall, the bladder dome, and you see an endometriosis nodule sitting on the bladder. It's about 1.5 or 2 centimeters big, so you can see that there is endometriosis in the pelvic cavity, and you can stage it accordingly. So going further with further endometriosis nodules, you can see this is retrouterine, and this is the rectal wall, and it's highly extended. This is the hypoechogenic area here, so the black area here. This is a rectal nodule of endometriosis. So this is also a rectal endometriosis. This patient has also rectal symptoms. Sometimes rectal endometriosis patient don't have any symptoms, but it's very clear that there is a rectal endometriosis affecting the rectum, and you can classify it according to the Astram stage as a second stage, and according to the NCN as C2 affection, so the affection of the posterior compartment of the pelvis. So going further, sometimes you see behind the uterus there is a hypoechoic area highly attached to the posterior fornix of the vagina in a retroflected uterus, attached also to the retrocervical area. This is a retrocervical endometriotic nodule, and there is no bowel affection in this area, maybe superficial one, but not an infiltrating one. But this is a big nodule behind the retrocervical area, and this is also a kind of endometriosis. So according to these data, we can see if the endometriosis is advanced one, is extending, affecting a lot of positions, a lot of sites. Seeing this endometriosis lesion, we can confirm or at least highly suspect that there is endometriosis, especially a peritoneal one, maybe bladder one, maybe rectal one, and classify the endometriosis as a minimal endometriosis, just a very small nodule on one side, or mild one, or moderate, or even severe stage of endometriosis, if you are seeing a lot of endometriosis distributed, extended in all the pelvic cavity. And the more extended the endometriosis is, the lesser the prognosis will be. And this is back again to the endometriosis fertility index. Not to forget, this is a third factor. The advancement, the extent of endometriosis is going to help us to classify the patient as a good prognosis patient or poor prognosis patient, depending on this ultrasonographic finding. Patient with minimal endometriosis still have good prognosis to get pregnant on a natural way. Patient with advanced endometriosis is going to have poorer prognosis or poorest prognosis to get pregnant on a natural way. So coming to the last one, and I really find it's very interesting to see even adhesions. So the patient in our clinic, in my clinic as well, they are impressed. How can we see the adhesion using the ultrasonography, and again without the necessity of laparoscopy? This is something that I have to say, I learned it from Katarina from Rome. She is a very experienced sonographer for endometriosis, something like about 2015, 2016. And I repeated it in my clinic, in my own practice, till I got so a very efficient experience to see it and to make it with the ultrasound. So sliding sign is depending on the fact that if you are pushing your ultrasound probe in the posterior fornix of the uterus, and with another hand you push on the belly of the patient, so you can usually get the uterus sliding away from the intestine. So sliding, positive sliding sign, this is a normal one. That means there is no adhesion limiting the sliding of the uterus on the intestine. But if there is adhesion between the uterus, between the upper part of the uterus or the lower part of the uterus with the underlying intestine or colon, so the uterus will be fixed. So remember, frozen pelvis, this is fixed pelvis, this is negative sliding sign. Nothing can be moved away or nothing can be sliding. And let us see some positive sliding signs, so normal sliding signs. This is uterus anti-flected, and you see this is the bladder. I can push the bladder smoothly and gently away from the anterior wall of the uterus, so I can exclude adhesion in this vesico-uterine pouch. This patient is not going to have adhesion between the bladder and between the uterus. And this is the anterior compartment positive sliding sign. Behind the uterus, you have the posterior compartment, and you can do the sliding sign, thus changing the ultrasound machine from the anterior fornix to the posterior fornix, and you see this is the colon is sliding very nicely and very smoothly over the posterior wall of the uterus and the posterior wall of the cervix. This is another positive sliding sign in the posterior compartment, so in the Douglas pouch in the pelvis. Again, we have two other more compartments. This is the lateral compartment. This is an ovary during an ovarian stimulation, and the patient doesn't have any endometriosis. And if you push the ovary away from the ultrasound bulb, you are seeing the ovary is sliding nicely and gently over the peritoneum. So there is no there is a positive sliding signs. There is no adhesion between the ovary, neither with the uterus nor with the peritoneal covering in the ovarian fossa. So this is the positive sliding sign in 4 compartment. Now, what about negative sliding sign? This is again a bladder endometriosis, another case, but you see the endometriotic lesion is invading the anterior wall of the uterus, so making the bladder is not sliding away from the uterus. This is an indication of endometriosis, and this is a sign of adhesion in the vesico-uterine pouch. So if you have a negative sliding sign, just keep in mind you have to search for deep endometriosis, for endometriotic lesion that which are the probably the cause of this negative sliding sign. So changing to another one, we have a negative sliding sign in the ovarian compartment. Let's see, this is the ovary, and if you see the ovary, I am trying to push it away, but underlying there is an endometriotic lesion as a nodule, and this nodule is tightly adherent to the ovarian surface, and this is a negative sliding sign of the ovary. And if you have seen a negative sliding sign, please search for endometriosis lesion on this side, because this is actually, or this is usually the cause of negative sliding sign. You can see the great difference between a negative sliding sign and a positive sliding sign. It's a very simple test. Doesn't take more than 10 seconds, 20 seconds to test. Here, another example of the ovarian compartment. I see the endometriotic cyst. This is endometriosis, but this endometrioma is tightly adherent to the posterior wall of the uterus. This is what we call, this is a part of frozen pelvis. If you are going to operate this patient, you are going to face a big endometrium, and it's tightly adherent to the posterior wall of the uterus, and you are going to need a multidisciplinary team doing the surgery. So this is very important for endometriosis surgeon to prepare everything for this big operation, and this is very good as a pre-operative management or pre-operative diagnostic for the endometriosis patient before going through the operation. But now for us as fertility specialists, I would say this is a massive adhesion in the ovarian fossa between the endometriotic cyst, which is already big. So she has an advanced endometriosis and she has an advanced adhesion. This is usually, I would classify this patient in a poor prognosis patient. Here, a very interesting case. You see, this is a as this is the ovary, and the ovary is completely adherent to the peritoneum. The peritoneum is affected, and you see the adhesion strength between the ovary, between the surface of the ovary, and between the colon. And between the strands, you have a fluid collection. This is what we call pseudocyst. Pseudocyst in the Douglas pouch. This is usually also a kind of frozen pelvis, sometimes with marked and fixed adhesion, thickened adhesion in this way. So we can summarize with this sliding sign. Whenever you see a negative sliding sign, a negative is a pathological one, you downgrade the tube ovarian function, because there is endometriosis affecting the tube, may be involved in this conglomerate involving the tube with the ovary, surrounding the whole ovary, so that ovulation can be happening, but the oocyte can't find a way to reach the tube, and upgrade the clinical stage of endometriosis, because more endometriosis and more adhesion, adding more points to the ASRAM classification, changes the patient from stage 1 to stage 2 to stage 3, and can indicate the presence of a deep infiltrating endometriosis, as you have seen with the rectal endometriosis or with the bladder endometriosis. Okay, so Dr. Mohammed, we have now done everything. We have heard our patient. We asked her actively about her symptoms. We did the ultrasound exam with 4 goals to examine, to check the ovarian function, the tubal function, extent of endometriosis, and the tubal function. And now we have to answer this question. Can I get pregnant spontaneously? So going back again to this endometriosis fertility index, we have good prognosis patient according to the history and according to the sonography, not surgery. And we have poor prognosis patient according to history and according to sonography. And we can go further depending on it. If you have a young patient with a very short duration of fertility, and you did an ultrasound and you have seen a very minimal endometriosis, positive sliding sign everywhere, and you tested the tubal patency, it was patent. So spontaneous conception is possible. Maybe you have to consider laparoscopy in this case, because excision of peritoneal endometriosis, according to the ERC guidelines, could improve or can improve the rate of ongoing pregnancy. I just imagine it, you have a house and you have to clear it up for your guests. And so if you are going to clear the pelvis from this minimal endometriosis lesion, so you are improving the milieu for the oocyte, for the sperm. It's just like a theoretical thinking. And a lot of patients is going to get pregnant in a natural way. Even helping them with insemination with some sort of mild ovarian stimulation would be very helpful to increase the pregnancy rate. So excise the peritoneal endometriosis and go for insemination for this patient because they have very nice chances. And please, please, please don't put this patient on a post-operative hormonal therapy, because it's not going, they are not going to benefit from this post-operative hormonal therapy. As you see with the endometriosis fertility index, the spontaneous conception rate in the first 6 months is very much high as 40%. So this is a very golden area. This is the golden time to get your patient pregnant on a natural way. So please don't put your patient on a post-operative hormonal therapy just after laparoscopic excision of minimal endometriosis. Just let her to get pregnant, just let her to ovulate and to have timed intercourse or going for insemination for at least 3 to 6 months. A lot of them are going to get pregnant in a natural way, and the patient will be very thankful for you. So another scenario, this is a poor patient. This is a very old one, so about 40 years old, having infertility of more than 5 years, hasn't been before pregnant. And with the sonography, I see bilateral endometrioma and I see negative sliding sign with frozen pelvis with pseudocyst. So this is for sure I am going to go for ART, so for the IVF, and this is actually what the ERC guidelines in 2022 also told us. ART can be performed for infertility associated with endometriosis, especially if the tubal function is compromised, if you have seen a hydrothalamic, if there is a male factor. In case of low endometriosis fertility index, this is a poor prognosis patient, and there is no specific protocol for ART, but it's a matter of discussion again, and we can spare it for another talk. So the third scenario, this is the same patient, old one, so 40 years old, 5 years of infertility, hasn't been pregnant before, but you have done the ultrasound and you have just seen a very small peritoneal endometriotic lesion, positive sliding sign everywhere. You tested the tube, everything is nice. Can you let her to get spontaneously pregnant? Actually, yes, but we have another problem, and this is the biological clock of this patient. This is outprint from the German IVF register, and if you can see here, starting from the age of 40, we have a much decreasing in the probability to get pregnant even after IVF. So the clinical pregnancy rate is decreasing dramatically starting from the age of 40. So for the sake of the age and for the sake of this advanced maternal age, I would send my patient to the IVF program. The last scenario is your patient is a young one, she has a short duration of infertility, and you have done the ultrasound and you have the same advanced endometriosis. So unilateral big endometrioma with peritoneal endometriosis with negative sliding sign, but the tube is still preserved. So you can go for ART, for IVF, or you can consider complete excision of these endometriosis, but may have to be done in a very should be done in a certified endometriosis clinic. So I know Horace Roman. He is a good friend of mine, and I would trust him if he told me I can get the endometriosis fully excised from this patient and to preserve the function of the ovary and of the tube again, so I can go for spontaneous pregnancy or for trial for spontaneous pregnancy. But if he told me it's going to tell me, no, I am not going to get all this endometriosis excised, so I will go straight for IVF. So actually, these patients are a candidate for IVF, except if you have a very good endometriosis surgeon, so that you get the endometriosis fully excised. So we can summarize when to do ART: advanced maternal age, long-lasting infertility with moderate and severe compromised ovarian and tubal function, with moderate and severe endometriosis and or adhesions. And as usual, there is nothing a wonder and a wonderful one, and index without disadvantage or without leaks. So we have the endometriosis fertility index. It's not including the adenomyosis in this classification, in this index, and is not including the male factor in this index. And the adenomyosis is a very, very big topic. I can't cover the adenomyosis today as well, but the adenomyosis can be very nicely seen with the ultrasound, with this cystic myometria, mole asymmetry, hyperestrogenicity, fan-shaped shadow. There's the Musa criteria, there's the direct sign, there's the indirect sign of adenomyosis. We can keep it for another talk, but if we want to summarize the effect of endometrioma and adenomyosis on the reproductive outcome of this patient, we would say having an endometriosis is usually affecting the folliculogenesis and the number of the ovarian, of the antral follicle count, so the ovarian reserve, but it's not going to much affect the clinical pregnancy rate, the quality of the oocyte. However, having adenomyosis have a much dramatic effect on the implantation failure, and even for problems for placentation, and even with a premature delivery. So the adenomyosis has a different kind of entity of endometriosis. So we can conclude we have a lot of endometriosis patient. We can suspect the diagnosis just inquiring about this syndrome, this symptoms, and we can confirm the diagnosis at least with a transvaginal sonography. And according to this endometriosis fertility index, using it as a clinical one, not an operative one, so we can decide, we can counsel our patient if they can get pregnant on a natural way, or if they have to go through an IVF. At the last, this is my favorite slide, actually. This is endometriosis, and this is a multifaceted disease. So not every endometriosis patient is the same. So please, we don't have one size fits all in endometriosis, and I hope that we, in the near future, we are going to opt from using the term endometriosis, but sticking more to specify which type of endometriosis, because patient with adenomyosis is behaving different than endometrioma, behaving different from deep infiltrating endometriosis, behaving different from peritoneal endometriosis. I think I am finished now. Many thanks for you. This is a wonderful team here in Germany, in Northwest Germany. We are doing a great job here. We are a certified endometriosis center, as well as a certified IVF center. And please, let's connect. Feel free to connect with me. I will be much more than happy to exchange with you. And many thanks for your listening.
Thank you, Dr. Mohammed, for the very nice and informative lecture. You have some questions are waiting for you.
Okay, let's go.
So the first question is, people are saying it's an excellent one. Based on ERC guideline, can we give diagnosis of endometriosis based only on symptoms? As we know, we cannot exclude peritoneal endometriosis based on normal ultrasound.
Based on symptoms, not. But in the ERC guidelines, it's saying with ultrasound. And this is, again, the ultrasound is now I would say this is the gold standard, or it should be the standard for the diagnosis of endometriosis. But again, coming back to Dr. Fatma lecture, if there is a negative ultrasound findings, but you still have suggestive symptoms of endometriosis, you should go for laparoscopy. This is an indication for going for laparoscopy if you are still suspecting endometriosis. Also, ultrasonographic in an experienced hand didn't detect any endometriosis.
Next question is Relugolix. It's an oral antagonist licensed for endometriosis. My understanding it was licensed for management of fibroids. I'm not sure it has been changed.
Yeah, actually, this is another talk. I give also a talk on Relugolix because I have experience with Relugolix here in Germany. We have got it licensed by the national German authorities from November last year, and I am using it now in infertility patients, especially having adenomyosis, and especially this big adenomyosis, going through the IVF with freeze all, and then going for down regulation for 3 to 6 months, follow the patient up, and then go for a two cycle. I think we maybe at the end of this year, maybe in the beginning of the year, we are going to present our data about this approach. But Relugolix, yes, has extended its indication not to cover only the myoma patients, the uterus myomatosis, but also the endometriosis patient. And I think I have been on the ESHRE this year and on the European endometriosis this year as well, and they are all talking about including the Relugolix in the next upcoming ESHRE guidelines for endometriosis as the first option, together with the gestagen, with the synthetic progesterone.
Okay. So the next question, actually, I've never known that peritoneal endometriosis can be detected by ultrasound. It's my first time to know this, so thank you for this. So the question is how you differentiate peritoneal endometriosis from just dilated pelvic vessels?
Oh, this is quite challenging, but I'm coming from Egypt, and Egypt I have learned it from my professors. You have to keep or to go for a diagnosis or provisional diagnosis depending on your history taking and about your clinical examination. So I trust my patient. I keep my ears listening to my patient as if she is suffering and complaining of pain, which is suggestive of endometriosis, and I see this lesion with ultrasound, so this is highly suspicious for endometriosis. Again, I check for everything, but to be honest, so lesion less than 0.5 centimeter, I can't detect it with the ultrasound. It's really difficult. But about 4 or 5 millimeters, so 0.5 centimeter, starting from 0.5 centimeter, you can detect it. But you have to learn. You see what you know, so you have to learn what you are looking for, so you are going to find it.
Okay, so next question is, what is the best protocol of ovarian stimulation with IOR in unexplained primary infertility with endometriosis?
Unexplained with endometriosis, it's difficult because so according to the definition, this is unexplained, or at least there's an association between endometriosis and infertility. So in case of endometriosis and after laparoscopic excision of minimal endometriosis in young patients with normal semen analysis, I would go for a mild FSH stimulation, because there is some studies that showed up that the clinical pregnancy rate using the mild doses of gonadotropin is going to improve the clinical pregnancy rate more than the natural cycle insemination or timed intercourse without ovarian stimulation. Sometimes I go for letrozole as an ovarian stimulation medication, but sometimes I use the FSH as well, but in a mild dose, so FSH.
Okay, one of our doctors is thanking you and saying it's a brilliant presentation. She wants to see you, and she has a question.
Thanks.
What's the best frozen embryo transfer protocol for patients with adenomyosis?
Okay, I can't answer this question because we don't know what is the best protocol. But I think yeah, theoretically thinking, and there is some studies coming also from China. They adopted this protocol, freeze all, and going for down regulation with GnRH analog for 3 to 4 months before going for a SO cycle. What we have modified in our center, that we use this protocol only in advanced adenomyosis. So I differentiate between this is a minimal adenomyosis or an advanced adenomyosis lesions. And I put my patient nowadays on relugolix, and I follow them every 4 months to do every 4 weeks to do an ultrasound. I measure the lesion of the adenomyosis. I have a 3D as well now, so I can compare the ultrasound pictures or photos every 4 weeks. So I can decide if there is a regression of the adenomyosis lesion, and if there is at least 40% regression of adenomyosis lesion, I go for suicide. This is just my own experience. Again, this is not based on a big clinical trial. We are still in need for big clinical trials.
Okay, thank you, Dr. Muhammad, for this
Welcome.
presentation. And if you have any questions, we'll answer it at the end. Thank you so much.
Thanks, Dr. Sameh.
Our last presentation will be Dr. Ahmed Zebda from Jordan. He's a member of the Royal College of Obstetricians and Gynecologists in the UK. He's also an assistant professor of Obs and Gynae in Balkay Applied University in Jordan. He is a visiting consultant gynecologist and endometriosis specialist at Oxford University Hospital. Let's welcome Dr. Ahmed. The title of the presentation is Unraveling the Enigma, Diagnosis and Management of Extrapelvic Endometriosis. So it will be he will continue what has been said by Dr. Muhammad. I think it's a very tricky scenario. So welcome, Dr. Ahmed.
Thank you. Good evening. مساء الخير للجميع. Professor Sameh, is my presentation on screen now?
Okay.
Can you see it? Shall I carry on?
Yes, you can carry on.
Thank you. I'm Dr. Ahmed Zebda. I'm a consultant gynecologist, endometriosis specialist. I trained in Oxford University Hospitals, did my postgrad training partly in Jordan, and then في مستشفى الأردن, and then في مستشفى جامعة Oxford for 7 years. I then worked as a consultant gynecologist and endometriosis specialist at the John Radcliffe Hospital. And I still work there as a visiting consultant in addition to my newly appointed job as an assistant professor at Balkay University in Jordan. No conflict of interest and no further affiliation other than the mentioned. And you can find more information about the extrapelvic endometriosis at the FIGO Global Women's Medicine Journal. So why do I call it enigmatic? Why did I come up with that title? It's because it is extrapelvic endometriosis. It's rare and it's underreported in literature. It can present to other specialties, so patients may not initially present to gynecologists, and they may present with a variation of symptoms or a variation of complaints. Other than gynecologists, doctors, other colleagues may actually miss or overlook the cyclical pattern, or what is usually described as the catamenial pattern of the symptoms. And they may not always have pelvic pain because they may not have had the established diagnosis of endometriosis, and also they may not actually have pelvic endometriosis. So when we talk about extrapelvic endometriosis, and we defined it as the presence of endometrial glands and stroma in locations outside the pelvis, but also in a distant site from gynecological organs, which means, like the picture on your bottom left where you've got rectal endometriosis, this is actually pelvic endometriosis and not necessarily extrapelvic endometriosis, although it's on the rectum. And also, when you look at the pictures on the right bottom corner, you can see a dilated ureter and an endometriosis nodule. Arguably, this is still in the pelvis, and therefore it's not extrapelvic endometriosis. But I have to admit that different authorities have come up with different definitions. But to try and make it simple, as long as it's in distant areas from gynecological organs and outside the true pelvis, then it's better to be called or to be named extrapelvic endometriosis. Now, how common is it? It's not very common. And again, it's rare and underreported in literature, and it can vary between 1% to 12% of patients with endometriosis. In reality, amongst women in reproductive age, it's less than 0.5%. But why would it happen in particular? Because the endometrium has a unique ability to maintain its function even in a distant location, because it can generate its new angiogenic attachments or vascular attachments, and it's receptive for hormonal stimulation and therefore can remain alive. Now, where can we encounter extrapelvic endometriosis? We can encounter it anywhere in the body. anywhere from top to bottom. And cutaneous endometriosis is typically one of the more common ones. It can occur on the abdominal wall. It can occur on scars. It can occur as well on vulvoperineal endometriosis. There is something called primary villus endometriosis, inguinal endometriosis as well. And like my colleagues have mentioned and spoke about, visceral organs can get involved as well in the abdomen, as well as thoracic endometriosis. And I'll be focusing on those ones, given that they are the more common ones. Now, what kind of symptoms could patients have? They could develop lumps or lesions because of those spots swelling and enlarging cyclically. Those lesions, if they are in close proximity to the skin, they may appear discolored because of hemorrhage. And if they actually invade into organs, they can cause, for example, bleeding if they're in the lung and cause hemoptysis. They can cause dysfunction of other organs, for example, cyclical or catamenial pneumothorax. If endometriosis is present in the brain, it could cause seizures or cyclical headaches or coma. In the liver, it can cause some sort of liver dysfunction, which can present with elevated liver enzymes or jaundice. And if it affects deep locations in the peripheral nervous system, it can cause neuropathy. Now, let's tackle first the cutaneous endometriosis, which can affect the abdominal wall. And it's because it's present, those endometrial-like tissues in the skin and the subcutaneous tissues or in facial layers. And the more common ones are the post-surgical ones. And the index surgery is commonly a cesarean section or a myomectomy, or a tubal ligation or a hysterectomy or an episiotomy. The whole idea is that the exposed endometrial cells from the endometrial cavity can actually bind to the fibrinous, fleshy surfaces of incisions. And again, because of angiogenic and hormonal activity, they get stuck and become active. Cutaneous endometriosis on the abdominal wall is present in around 5% of women who have extrapelvic endometriosis, and approximately 18% of those patients who have abdominal wall endometriosis also have pelvic endometriosis. Cesarean section scars remain the most common sites, and I'm sure all my colleagues have encountered this, and they can present with the mass. This mass might be reaching the skin, causing discoloration. This mass typically swells with the period or with ovulation. And sometimes can be missed because of skin complexion, or sometimes can be missed because it's not too close to the skin and not seen. So detailed history as well as a thorough examination is essential. My colleagues have spoke about imaging, and imaging can be performed from ultrasound scan to CT to an MRI. And when it comes to an ultrasound scan, if you focus your scan on the anterior abdominal wall, you might find a single, a multiple, or cystic, multicystic, or even a solid lesion. And the way it would be described on an ultrasound report would be anywhere between a hypoechoic to an echogenic spots, and it could have echogenic strands or fibrotic elements. The reason why, or the concentration of hemorrhage versus fibrosis is really related to the percentage of endometrial glands causing hemorrhage inside this lesion. And they could show vascularity at Doppler ultrasound, but that is also variable according to the time when the scan is performed and whether the patient is actually menstruating or ovulating or not, or if she is receiving hormonal suppression. On MRI, it's quite useful because it gives us the extent and depth of this lesion. And if it's attached to the rectus sheath, it tells us the depth of invasion if it goes beyond the rectus sheath into the rectus abdominis muscles. And it's quite necessary for preoperative preparation because from a gynecological perspective, if yes, we can potentially treat superficial cutaneous cesarean scar endometriosis, but if it's in deep location causing damage to the rectus sheath, then probably a plastic surgeon or a general surgeon that is more equipped or more used to deal with deeper lesions and repair of damage to the sheath or to the rectus abdominis with mesh. Now, on MRI, it can show ISO or high signal intensity on T2 and T1 weighted sequences, and it could show hyperintense foci on T1 weighted images with fat suppression. It's actually quite helpful in inguinal endometriosis because in inguinal endometriosis, the fat suppression helps you identify it in relation to other fat in the area. I'll get to that later. I just want to show you this small video. Do you still see my screen?
Yes, we see your screen, Luke.
So on this video, you can see that there is an endometriotic nodule that's gone beyond the anterior leaflet of the rectus sheath on the C-section scar, right, with attachments to the rectus abdominis muscles, and it's quite a sizable nodule. Here in this case, it actually damaged it's in close proximity to the retsia space and the pubic bone, and it actually damaged a good proportion of the rectus abdominis muscles. And here you can see that a mesh was actually required for repair of that significant defect. And this is why it's important to work in a multidisciplinary fashion to ensure that the optimal treatment is provided for the patient. Now, vulvoperineal endometriosis is actually a rare subtype, and it happens in less than 0.5%. And it could happen following obstetrical injuries, such as lacerations or episiotomy scars. Interestingly, it could happen after gynecological surgery, such as Bartholin glands excision. It has a median latent phase for around 2.5 years from the time of the laceration till the time of presentation. Theories to explain it is probably mechanical implantation, such as very similar to cesarean scar endometriosis. However, there could be lymphovascular spread from the round ligaments towards the labia majora, and coelomic metaplasia is a good theory for Bartholin's gland endometriosis. Now, in episiotomy endometriosis, it's really important to take detailed history and physical examination, and physical examination should involve as well a rectal examination to assess whether this lesion is in close proximity to the anal sphincter and if there is any damage to the anal sphincter complex muscles. Ultrasound scan and endoanal ultrasound scan might be useful, as well as MRI. When you look at a patient who presents with a Bartholin cyst enlargement, probably the last thing you would guess is this is going to be an endometrioma of the Bartholin cyst. Similar to the picture on the bottom left, where it actually looks straightforward like a Bartholin cyst. Maybe when it presents with a more multicystic discolored lesion like the picture on the right, then it might trigger the suspicion for endometriosis. However, other differentials, including a melanoma and skin cancers, should not be overlooked. One interesting extrapelvic endometriosis is called Villus nodule, or primary umbilical endometriosis. And it's called primary because it comes without any history of previous surgery or previous obstetric surgery or previous endometriosis surgery. And I want to differentiate between primary villus nodule and umbilical trocar or umbilical port site endometriosis. Umbilical port site endometriosis is a scar endometriosis that usually occurs after pelvic surgery or gynecological surgery. Whereas this one, primary umbilical endometriosis or villus nodule, happens without any previous surgery. It was first described by Viller in 1886, and it tends to take a long latency phase due probably to long exposure of inflammatory mediators or long exposure of hormonal mediators, with a mean age of 37.7 years. There are several theories. One is the metastasis theory, where spread of endometrial cells via lymphatics or the blood leads to those endometriosis spots in the umbilicus. And there is the metaplasia theory, where there's changes in the peritoneal mesothelial cells due to hormonal or environmental factors. These present usually, or they may present to general surgeons or plastic surgeons rather than gynecologists. And the lesions might be cystic, like a single cyst, or a multicystic, and they may vary in their presentation depending on the time of the period, and that also may have an influence on the color. So a more violaceous pink-red color may probably indicate hemorrhage, whereas a darker or pale areas might indicate fibrosis. we shouldn't miss other potential differential diagnoses such as melanomas or cystic Mary-Joseph nodule, which occurs with simultaneous visceral cancers, and it could be pyogenic granulomas, hernias, and pemphigus vegetans as well. What about inguinal endometriosis? To know about inguinal endometriosis, it would be quite helpful to understand a little bit of the anatomy of the canal of Nock, which is this canal that represents an anatomical defect when the parietal peritoneum or when the parietal peritoneal pouch follows the gubernaculum during embryological development. The female gubernaculum extends proximally, as you can see from the round ligament, all the way down through the inguinal canal to its subcutaneous insertion in the labia majora. So cystic endometriosis can occur within this hernial sac, or solid masses can actually present all the way down to the labia majus or labia majora. And in the picture, you can see in the right bottom corner, you can see it in the pelvis, right at the entry of the round ligament, occasionally associated with some sort of herniation of the peritoneum as an Allen-Masterson's pouch, or if it's a cystic or a solid lesion down to the skin, into the skin of the inguinal area as well. The more common theory, it's retrograde menstruation, and that explains the higher chances of having inguinal endometriosis on the right, because retrograde menstruation is probably blocked from the left side by the sigmoid colon that occludes the inguinal area or the inguinal canal. And therefore, you tend to see it more on the right side, and that is seen here in the pictures at the bottom right. Now, how do we manage cutaneous endometriosis, all of the skin-affiliated endometriosis? Of course, correct diagnosis by taking thorough history, listening to your patients, doing a detailed examination, and referring to colleagues when necessary. Ultrasound, MRI, and CT scan can all be helpful. Fine needle aspiration, you tend to receive referrals from your colleagues in dermatology or in general surgeons having performed an FNA with variable sensitivity. It may or may not pick up areas of hemorrhage or endometrial cells, because this really depends on the stage of endometriosis that FNA is being done at. So it has variable sensitivity and specificity. When it comes to hormonal management, it is useful for symptomatic control, especially in patients who are not troubled with those lesions. In some patients who wish to avoid surgery, for example, a woman who is perimenopausal and wishes to avoid surgery on her perineum that could involve damage to her anal sphincter, hormonal suppression or a conservative approach might be a good idea until establishing menopause. There is evidence that post-operative hormonal prevention is beneficial to try and reduce the recurrence rate. Overall, surgical excision with clear margin is optimum treatment. It allows for less recurrence, somewhere between 5 to 10%, but you have to bear in mind the implications on adjacent organs and whether or not a multidisciplinary approach with specialists in abdominal wall surgery or rectal surgery are needed. There's a whole entity called visceral endometriosis, which has a mean age of 40, which also reflects a longer latency period. And it also, the same retrograde menstruation theory is a good theory to explain visceral endometriosis, particularly for intraperitoneal organs. Whereas lymphovascular theory is a good theory to explain retroperitoneal organs developing endometriosis. And it really depends on the location this time, and whether it would just be simply pain and swelling, whereas if it's on the small intestine, the presentation might be bowel obstruction. If it's on the liver, it can be a mass effect or liver failure. On the pancreas might present with pancreatitis, and patients might have recurrent urinary tract infections or hematuria if it presents on the kidney. CT scan is typically good for visceral organs, and certainly a multidisciplinary team approach is necessary for optimal management. I'm going to talk about thoracic endometriosis, or TE, which has a lot of publicity these days. And it's the final segment of extrapelvic endometriosis I'll be discussing with you. And it's defined as the presence of endometriosis within the thoracic cavity. And based on this definition, the diaphragm, pleural surfaces, the lung parenchyma were all considered part of the thoracic cavity or thoracic endometriosis. It is one of the most common forms of extrapelvic endometriosis, certainly with significant clinical implications. And it does have an older age of presentation compared to pelvic endometriosis. And there's a very strong association between thoracic endometriosis and pelvic endometriosis, and most patients who have the vast majority of patients who have TE have pelvic endometriosis as well. Patients typically present with pelvic symptoms for around 7 years before developing TE symptoms. And the thoracic diaphragm is the most common location, followed by the visceral diaphragm. Theories that explain thoracic endometriosis include the Sampson's or retrograde menstruation, where the endometrial cells from retrograde menstruation go to the right hemidiaphragm. This is likely because the ligament falciform and the phrenocholic ligament obstruct the retrograde menstrual flow to the left hemidiaphragm. And then the transperitoneal to the transdiaphragmatic migration to the pleural cavity can happen because of congenital or acquired fenestration within the diaphragm, very similar to Meigs syndrome in benign ovarian cysts with a tendency for the right side. Again, it's the same. And those fenestration or those holes or those openings that occur at from the peritoneum to the diaphragm are probably are likely the passage or the path for endometriosis to invade into the pleural cavity and to the lung. The coelomic metaplasia theory says that endometriotic cells arise by metaplasia of mesothelial cells, but this fails to explain the right side predominance. The lymphatic and vascular dissemination theory, again, it doesn't explain the right side predominance, but explains why some patients have lung parenchymal endometriosis and may have hemoptysis outside their menstrual cycle. Now, the symptoms could be anywhere between chest, shoulder, or upper abdominal pain. Rib pain is commonly described, and catamenial or cyclical pulmonary symptoms such as a cough or hemoptysis or cyclical hemothorax or pneumothorax. If pneumothorax happen to define it as a catamenial pneumothorax, we want 2 episodes of pneumothorax that are related to the onset of menses, usually within 3 days or 72 hours. And interestingly, it accounts for up to 25% of spontaneous pneumothorax in young women, and usually presents with shortness of breath, cough, pleurisy, chest pain, shoulder pain, with scapular or cervical radiation. And the theory for the pneumothorax is either transdiaphragmatic air leak during menses, or pulmonary endometriosis causing rupture or perforation for alveoli. And there's prostaglandin F2 alpha increase during menstruation, causing vasoconstriction, bronchospasm, and alveolar rupture. Usually, patients do not present to gynecology. They would present to A&E or to the emergency room, and they would get a chest X-ray, which could demonstrate areas of collapsed lung globes, or if an MRI is performed, you could either see hyperintense lesions or hypointense lesions on T1 or hyperintense lesions on T2. CT scan can be good for pneumothorax, however, it is not really specific, and we should be all aware of the CT scan implication on the breasts of young women and not to expose them if unnecessary. MRI remains superior because it can pick up soft tissues in a better way, and particularly for diaphragmatic, pleural, and hemorrhagic regions with a very good sensitivity up to 83%. Now, this is how it may appear. First, from the diaphragmatic from the intra-abdominal view, these fenestrations can be seen, and inside the lung itself when VATS is used. And VATS is very similar to what we do in the pelvis. It's very similar to laparoscopy, video-assisted thoracoscopy, and it is considered the gold standard for diagnosing pleural or even full-thickness diaphragmatic lesions. And it gives you the opportunity to explore as well as to treat. And I couldn't upload this video, but I will try and show you the video if possible. Well, maybe not possible. All right. Right, moving on. Right. So, treatments. Hormonal and surgical are options. You can either offer patients continuous combined contraception of progesterone only in a continuous fashion, Dynagest and GnRH agonists, and as my colleagues have presented, antagonists are commonly a new addition. All can be used. The purpose is to suppress ovarian steroid hormone production, reduce menstrual bleeding, and reduce cyclical or catamenial symptoms. Unfortunately, 50% of symptoms will come back upon discontinuation, and surgery should be considered for refractory or recurrent cases, and postoperative hormone suppression can be considered. Now, specific surgical treatments, if there's superficial pulmonary implant, it can be treated by diathermy, by carbon dioxide, or ND-YAG laser. Deeper lesions need excision. Lung parenchymal lesion might need wedge resection, or all the way up to a lobectomy. And there is less invasive treatments, especially for recurrent pneumothorax using chemical or medical pleurodesis. And of course, in combined procedures, a multidisciplinary approach using both traditional laparoscopy as well as VATS to treat simultaneously pelvic as well as diaphragmatic and thoracic endometriosis in fit patients, of course. Diaphragmatic lesions are usually identified through laparoscopy, and if there are any larger defects, the use of synthetic mesh is necessary. Sometimes VATS and laparoscopy are needed if there's full thickness lesions extending from the intraperitoneal side all the way to the intrapleural side. And it's not an easy operation, comes with complications such as pneumothorax, hemothorax, air leak, pleural effusion, and of course, as well as vascular injury and nerve injury causing diaphragmatic paralysis or Horner syndrome or a hernia. And unfortunately, it does come with higher recurrence rate because it's very hard to clear all of the pelvis or all of the pleural cavity from endometriosis. Now, because there's, like I said, there's a lot of talk and a lot of attention over thoracic endometriosis, the British Society of Gynecology Endoscopy, as well as the Royal College of Obstetricians and Gynecologists, published a statement that aims to increase awareness of thoracic endometriosis and improve clinical outcomes by allowing higher caseloads within few specific units in the UK, to allow greater experience for doctors and acquisition of expertise as well, and to coordination of multidisciplinary care within specialist centers in the UK. Now, the last thing I want to talk about is the potential for malignant transformation of extrapelvic endometriosis, which occurs in around 1%, and it's not common. However, we should be aware that recurring and rapidly enlarging lesions are more likely to transform into cancer. Abdominal wall, cutaneous, or scar endometriosis has a very poor prognosis, and therefore I'm more inclined to offer patients with cutaneous or cesarean scar endometriosis surgery rather than simply hormonal suppression. Clear cell carcinoma and endometrioid adenocarcinoma are the most common subtypes of cancers we see in those lesions. And whenever that is diagnosed, as in cancer is suspected or diagnosed, then treatment should involve a wide excision of the area with clear margins and adjuvant chemotherapy or radiotherapy. Finally, suspect endometriosis in any extrapelvic site whenever there are cyclical or catamenial symptoms. Consider hormonal suppression to relieve symptoms and reduce recurrence. Wide surgical excision of lesions when appropriate, and probably is the best for cutaneous endometriosis, and a multidisciplinary approach involving specialists for tailored management optimizes patient care and outcomes. And like I said, suspect cancers if it's recurring quickly or if it's rapidly enlarging despite treatment. And I spoke about the centralized care benefits, which include expertise development with sufficient case numbers, improve patient safety through experienced management of complex surgical cases, and establishment of research infrastructure for data collection and evaluation of interventions. Thank you very much for the audience and colleagues, for Professor Yasser Abu Talib, and for the Egyptian Representative Committee for the RCOG and the IRC for the MENA region.
Thank you, Dr. Ahmed, for this informative presentation. Thank you so much. And we have a question asking you, what's the best timing for management of endometriosis in an episiotomy?
Well, I think we should tailor treatment according to the case. If it's symptomatic, large, and causing disruption to level of function, sexual intercourse, and quality of life, then it probably shouldn't be left alone. However, arguably, some may say if the patient is keen to conceive and wants to deliver more babies, then wait until the family is completed. So I will be guided by patient symptoms rather by a specific timing or a blanket cover timing for all patients.
Okay, other question is asking, do you think that anal ultrasound in preference of vaginal ultrasound is better for cases of bowel endometriosis or rectal endometriosis?
I think Professor Muhammad, his expertise here can give a better answer, but I would still go with a vaginal ultrasound first and leave endoanal ultrasound to evaluate for the involvement of the anal sphincter in case of perineal endometriosis. But I would like to hear the answer from Professor Muhammad as well.
Okay, before going to Dr. Muhammad, okay.
Guys, good.
Dr. Muhammad, yes.
First of all, thanks a lot, Dr. Ahmed, for this very, very nice talk. In my own experience, I usually do the transvaginal ultrasonography, and I can detect the rectal endometriosis, sigmoid endometriosis very, very nicely. I usually use the endorectal ultrasonography because this was one of the questions addressed. In virgin patient, because I have a lot of Arabic women who are virgin here in Germany, and they come complaining of endometriosis, and I just explain the examination, and I do the transrectal ultrasound. It's fantastic. It's the same one-to-one as a transvaginal ultrasonography. So I would go for a transvaginal or transrectal if she is virgin.
Okay, so this question for all the three speakers, if anybody want to answer, the role of radio frequency microwave ablation in endometriosis.
I would like to start. Yeah.
Okay.
So I don't have my own experience with radiofrequency ablation. We have here the HIFU, the high focused ultrasound ablation of adenomyosis patient or adenomyosis uteri. I didn't get experience till now with HIFU in infertility patient, but still we have upcoming results coming from other hospitals testing it on about 35 patients, I think, with infertility, and it seems to do well, but we have to wait more to see the final results. But the radiofrequency ablation, I think, talking about pain with endometriosis is different, completely different from talking about infertility with endometriosis, with having the adenomyosis. I would say it doesn't have any rule for the moment until we have much more data in infertile patient.
I think we have to be very careful about these new technologies. The last thing you want is to inflict harm on a patient trying to conceive. So just be really careful before offering these treatments that they have, probably very promising in the future, but we still have limited evidence for their safety.
Can I interpret on this?
Dr. Fatma?
Yeah. I have an experience with the radiofrequency ablation regarding a chronic pelvic pain patient. Doing the ablation for like ilioinguinal or like perineal or internal like nerve ablation with chronic pelvic pain associated with endometriosis.
Okay, that's great. Two doctors are asking, what about the perineal ultrasound, not the endoanal?
I think perineal ultrasound can be helpful as well. We can use it in obstetrical cases and to identify location of placenta. So, I mean, in terms of given that there is the proximity from the perineum to the pelvis is not that, it's not a long distance. So you can still obtain good, high quality pictures because the high frequency is going to work there. I don't think it's going to give us the sliding signs. I don't think it's going to give us interpretation of point tenderness in the pelvis. So yes, it will be helpful potentially, but we're still missing out on some beneficial points we can obtain from an active transvaginal ultrasound scan.
Okay, Dr. Muhammad, any other opinion?
As I told you, I have experience with transvaginal and transrectal, and just remembering, so the case of last week, a 15 years old girl coming from school age, complaining of endometriosis. I have explained the examination in the attendance of her mother, and I did the transrectal, and it went very, very nice. And I do it in the last years very, very frequently, and it's widely accepted. I don't have any experience with transperineal.
Okay, Dr. Fatma.
Yeah, just to add, not to forget that MRI imaging can help. In the absence of expert using the ultrasound for diagnosing endometriosis, like Dr. Muhammad, not everybody is expert to do an ultrasound mapping for the disease or getting detected of the endometrial implant in the pelvis. I know we are missing the sliding movement and the site of tenderness, but MRI imaging with contrast can help to identify the disease, especially in the perineal area, reaching the anal sphincter if we have a good image and cut.
I totally agree. There's also the medical legal aspect to keep in the back of your mind as well. In the unit where I was training in Oxford, we used to do transvaginal ultrasound, and we used to get 85% sensitivity and specificity, almost similar to MRI, but we still ordered an MRI. So I agree to some extent that MRI is necessary, especially from a medical legal aspect.
Okay.
I just would like to add some one single comment regarding to the ultrasonography. I think, and this is my message to all attendees today, something like 6 years ago, 7 years ago, I wasn't such a good sonographer in endometriosis, but I heard about it, I learned it once, and tried to repeat it in my own clinic. There was also mistakes in the first trials, but after a certain period, you have a such high learning curve. I would give you an advice. I do till today the ultrasound examination by myself. Sometimes I send the patient for laparoscopy, and I get the operation report back, and I read it carefully to check for my ultrasound findings, if I was just using the endometriosis or not, and to check that side of this endometriosis. This is just like self-learning. So I would encourage all of gynecologists attending this webinar to try to start using the sliding sign to search for the ovarian fossa, search for the rectum, just starting very basic, very simple, starting from tomorrow, to see their patient, even if there is no suspect of endometriosis, to have the normal one, to find the abnormal one. And believe me, you are going to be good with ultrasonography, and you are not going to need this endo test. So just you can trust your eyes.
Okay.
Absolutely.
A question is asking, if the Indigest is not available, can she use Zoladex for life and the patient is not candidate for surgery? Dr. Ahmed?
What wasn't available? Rilogolex?
The Indigest.
Dynogest, okay.
Was the question on Zoladex, or was it on Dynogest?
If it's not available and the patient is not candidate for surgery, can she use Zoladex for life?
Well, the license for Zoladex is 6 months, can be extended a little bit longer with protection from osteoporosis, with hormone replacement therapy, basically, and probably biannual or 2-yearly DEXA or bone densitometry scan. But the challenge really is it fair to put somebody who's 25 on Zoladex to induce menopause for a good 25 years? Is that fair for patients? I'm reluctant to say yes for all. I'm definitely have to tailor this treatment, probably better for patients who want to use it temporarily or want to use it perimenopause, and surgery should never be off the table.
Dr. Ahmed, I think we can extend the length of the treatment if we have an add-back therapy.
Yeah, or in an off-license fashion with patient counseling, with HRTs and 2-yearly bone scan, yes. But again, the question, how nice is it to keep somebody
Yes.
who's for, you know...
Totally agree, but if it's not a candidate for surgery, maybe trying to get another option of treatment like Elagolex or letrozole for a long-term treatment with like a frequent episode of hormonal treatment and follow-up can be helpful for a patient with or not candidate for surgery.
Again, I think, but I can't say yes for all, but I think in some cases
it should be tailored according.
Yeah,
patient.
but my problem as well is there a patient who's not a candidate for surgery? Has maybe referred to a second opinion as well.
Okay.
I would just add a comment. As an IVF specialist, we established something like a video conference, so discussing the complex cases of endometriosis once monthly, and we are doing it on a routine basis. So every month I meet up with the endometriosis surgeon in another hospital. It's something like a half an hour away from our clinic, and we discuss with ultrasound pictures, with AMH, with every details about the history, and we decide if this patient is going to benefit from surgery, if the surgery is necessary, if she is a candidate or not candidate for surgery, and decide also the hormonal therapy. So I think the multidisciplinary approach is very important, and not to forget that there is non-hormonal therapy of endometriosis. Sometimes I send the patient for a pain therapist. Sometimes I send the patient for complementary medicine with traditional Chinese medicine, with acupuncture and something like that. And I would say it's not so the magic in the treatment of pain in endometriosis, but it could help. It could reduce the doses of this hormonal therapy. It could make cover so a period of time until the patient is ready for or coming a candidate for surgery or something like that, or just for a follow-up as well. So there is a multidisciplinary approach, especially for endometriosis patient with pain.
Okay, 2 more questions because I think you are very exhausted. The best IVF or ICSI induction protocol in case of endometriosis is it agonist or antagonist?
So I assume I have to answer this question. It's very difficult. In my own experience, there's no difference using agonist or antagonist in endometriosis patient. As I told you, one size fits all. We should opt it. For endometriosis patient, I go for antagonist, except for patient with endometriosis with severe pain. I have to control the pain to start with ultra-long protocol to get this pain controlled and then starting the stimulation. Or patient with advanced adenomyosis, so I start with antagonist, freeze, or with down regulation, and then cycle. So I tailor the treatment according to the patient condition.
Okay,
so this is a simple answer. No.
Okay, thank you. Dr. Fatma, the next question for you. If a patient is coming with endometriosis and she has a laparoscopy, and I would say pelvic nodule has been removed, and she's coming again complaining of pain, do you think she needs to be on hormonal treatment for a long time?
Regarding this patient, we have to image her before giving the answer of starting hormonal or what kind of surgery she had. Is it like extensive, good clearance of all endometriotic disease? And not everybody can perform laparoscopic surgery for endometriosis. Should be trained, highly specialized, know what endometriosis look like, and be careful when doing excision for endometriosis lesion, especially the one deep in the pelvis. or reaching the deep pelvic nerve. So hormonal can help after the surgery, but we should know more extra details about what happens during her first surgery. Because I believe in endometriosis, the first surgery is the best surgery and should be done by highly specialized doctor in endometriosis.
I think in every surgery, the first one is the best. Yes. Question is asking, do you think cyst aspiration can have a role? Endometriotic cyst aspiration, yes.
For me or for Dr.
Dr. Muhammad, then Dr. Fatma?
Okay.
Okay, so you mean cyst aspiration, so endometriotic cyst aspiration before doing ERC or IVF?
Or just as a treatment, if you have a cyst and she's feeling pain, so you just do a cyst aspiration. I know the recurrence rate is high, but do you think it has a role?
I don't do it myself. I don't have experience with this one. I think it doesn't have a role because you are still having the lining, the inner lining of the endometriotic cyst, and you have a recurrence. You expose your patient for high recurrence rate, for infection, and this is invasive. So, yeah.
And if you have a chocolate cyst in an ovary and you're doing an ovum packup, and this endometric or chocolate cyst is in front of you, we discard. Discard this ovary or just penetrate the cyst, aspirate it, and then go for the next follicles. What do you think?
I think I discussed this with the patient during the stimulation, during the folliculometry, because I test if the ovary is reachable, the affected ovary is reachable with the needle. And if I see there is some probability that this ovary is not going to be punctured, so I tell the patient and I focus on the other one, or I usually start with the healthy side and finish it up with the diseased one. If I got enough oocyte from one side, let's say 10 oocyte, and this is very difficult with high risk to puncture this oocyte, this affected ovary, so I will let it. But if I have to fight for this ovary because we didn't get any oocyte or it's a very low ovarian reserve, so I may try to avoid the puncture or to puncture the cyst, change the needle or wash the needle, and then to follow with the follicle puncture.
No, I mean you puncture the cyst and just pass through the next follicle, or aspirate the cyst first.
I aspirate the cyst first because I have a theoretically risk of leakage of the chocolate content inside the belly. So I aspirate the cyst and wash the needle, wash the system, and then go for the follicle puncture.
Dr. Fatma, any opinion? You just agree?
As Mohammed mentioned, it depends on the case. If the patient has a low ovarian reserve, or she has only one ovary due to previous history of ovarectomy, and she presented with an endometrioma, asking or desiring pregnancy, and maybe she will be benefits of the aspiration. Prior go to IVF cycle, especially if the IVF specialist has a difficulty for egg retrieval, and it's only single ovary. So
okay. Do you still have power and energy for 2 more questions?
Yes.
Sure. So there's a question saying the effect of acupuncture and physiotherapy. I think it's a bit difficult to answer this question.
The pain, but it's not like we have a solid data. We can add it for patient complaining of severe or chronic pelvic pain that affecting their quality of life. It could be helpful.
Complementary medicine.
For a second.
Oh, Dr. Ahmed is here now. You're back.
Yes, sorry, I'm difficulties with the internet. I think there's some new evidence. There's some new Japanese, if I'm not wrong, evidence on alternative medicine, like Dr. Muhammad said, as well as FODMAP diets, as in dietary elimination to reduce the triggers for pain.
I don't think they harm. And I think it's worth discussing with patients optimizing of their lifestyle, Pilates, yoga to strengthen the pelvic floor muscles and improve the pain threshold. Acupuncture might help, mindfulness might help, as well as, dietary elimination. So I think we should approach our patients in a holistic fashion.
Okay.
Agreed.
Okay. Another question is, a doctor is asking about, he's saying that open microsurgery is the best for frozen pelvis, not laparoscopy. What do you think about this?
Me as a laparoscopic surgeon,
You would definitely go to the laparoscopy.
yes.
Yes,
We have a difficulty
laparoscopy.
with open case, because open case you have to open the patient from up to down with a multidisciplinary team, and the patient should be well prepared for this kind of surgery. Even if we are going for laparoscopy, patient should be counseled well about the risk of converting to laparotomy for any intraoperative difficulty, especially if the team has a big role in this kind of surgery, like a colleague from the urology or a surgeon. But for me, going in a frozen pelvis, I prefer the laparoscopy. It's give a big, nice panoramic view, and with the camera, I can be squeezing, going deep down in small spaces that I cannot do it with open case.
Yes, I agree totally with Dr. Fatma. You get magnified images 6 to 8 times at least. You reach avascular spaces of the pelvis with the pneumoperitoneum would dissect for you. And you have a smaller scissor and a smaller tip dissector, so you achieve better planes and safer margins.
Okay, a question asking about what's called the triple approach. So laparoscopy and aspiration, followed by GnRH analog, followed by surgical excision. What do you think about this?
Sorry, again?
The doctor is asking about what's called a triple approach. So she or he is doing a laparoscopy, draining the endometriotic or chocolate cyst. After this, he gives or she gives an antagonist or an agonist. And after this, he's going back to do an open surgery for total excision. Dr. Muhammad?
So I am, as I told you, I am not a surgeon, but I think I don't have experience. I think it's just like theoretical thinking. So I would say Dr. Ahmed and Dr. Fatma are more are better to answer this question.
Do you think it has a role?
I feel it's weird. Why aspiration, then down regulating for the disease, then go again for excision?
Maybe she's looking forward to have a complete excision.
Why
I'm sorry?
Yeah. Why not having an excision from the first surgery?
She is saying this is a new approach, according to her experience. I don't know, to be honest, to reduce the damage of the ovary.
That's why this kind of surgery should be done by experienced surgeon. So, and the patient, like a priority, what's the aim of the surgery? Is the patient want a relief from pain? We have to go and excise it. If the patient is aiming for pregnancy and fertility, we can go for aspiration and send her for immediate IVF to give the best chance of conceiving, because the first 6 months is the critical after this kind of surgery because of the high recurrence rate of aspiration. So it's like a missing information. What's the full background history to go inside? If she's giving, if she's doing aspiration and giving a GnRH analog, then going again for excision, this is giving the patient more like exposure to surgery, and also we are like affecting her ovarian reserve if we are going twice on the ovary, to be honest.
Dr. Ahmed, do you have any opinion on this?
Before 2022 ESHRE guidelines, there was this idea of doing a two-stage procedure where you drain the ovaries first, then you come back 3 months later to do the full cystectomy. But I think the 2022 ESHRE guidelines have changed and said drainage and usage of cellulose sheets like for hemostasis, and allow that in cases of low ovarian reserve is probably optimal.
Yeah, this is what I mentioned in the presentation.
Okay, yes. A question for Dr. Papa, but I think it has been answered through her lecture about your experience with letrozole in deep-seated endometriosis.
It's off-labeled for endometriosis, but be effective. If we are thinking, what is a letrozole? Is a synthetic that help and used for a long-term therapy for breast cancer patient of a hormonal type. So using it for 5 to 10 years for women with breast cancer of a hormonal type to put the patient in under estrogen state, it helps theoretically with endometriosis. And when we use it with endometriosis, not like for 5 or 10 years, but like for alleviating the pain and minimizing the deep impacting disease, it helps using the letrozole. I've been using it up to like 2 to 3 years of a continuous fashion if the patient has no a real like sequelae or side effect of the medications, with monitoring the bone mass density.
Okay, last question. We have endless questions, but I think it's
it's a big talk.
Yeah. This is the case. I'm sorry where it is. He is saying one of the doctors, she has a patient, she's 32 years old, and she has a large endometrioma, which is 13 centimeters with MRI, reporting it is a complex cyst. However, on ultrasound, it has been shown as only an endometriosis, an endometrioma, a chocolate cyst, okay? After laparoscopic excision, the histopathology came back as endometrioid carcinoma FIGO stage 2. Her question, was it wise to do a laparoscopy or not? Start with Dr. Ahmed.
It's hard to tell, really. I'm sorry I can't have my video on. Whenever I switch it on, I lose connection. I think if it's such a big cyst, then it needs to be treated, probably causing the majority of the symptoms. You cannot disregard it even. But the challenge would be fertility index, AMH, and her desires for fertility. I think there's no, in my opinion, there's no one right, correct answer for such a case.
Dr. Fatma?
I agree with Dr. Ahmed. They proceed with the case as endometrioma. The risk of having ovarian cancer with endometriosis can be there, but depends on the patient age and fertility planning. If she's having the cancer and she wants to pursue her fertility, I think egg freezing for and then going for extensive like unilateral oophorectomy with follow-up of chemo or
yes, a multidisciplinary team.
Yeah, it's a multidisciplinary approach.
Yes.
We have to keep in mind doing a large endometriosis or endometrioma as size of 13, there is a big chance of puncture during the surgery and spillage of the material in the pelvis. So it's upgrading the case of if it turned to be ovarian cancer. So keeping this in mind, we have to be carefully counsel the patient and refer her to gynecologist for further and
okay, question. Thank you. Question for Dr. Muhammad. Do you think there is still a role for surgical tubal reanastomosis in, the era of ICSI and IVF?
Yeah, maybe 10 years ago, 15 years ago, there was here in Germany as well a well-known center in the Medical University of Hanover. The colleagues here were doing a lot of tubal reanastomosis, especially after sterilization OP. But I think regarding endometriosis, and if you have a disrupted tube and a compromised tube with salpingitis, esmeganodosa, something like that, I think it's nowadays it's not possible to reconstruct the tube without having a high risk for ectopic pregnancy. And as we have a very good advancement in IVF and ICSI and the clinical pregnancy rate, I would go for IVF or ICSI. I would go for IVF, not to a tubal reanastomosis.
Dr. Ahmed?
The challenge with tubal anastomosis is outcomes. It's hard to work on patients' hopes, really. So if there's distal disease, there is a few publications that suggest a 60 to 70% pregnancy rate afterwards. But if it's a proximal disease with the presence of endometriosis, then the likely would rather go for IVF.
Okay, I think we are coming to an end now. I can't hear you, Dr. Ahmed.
Oh, I'm sorry. Did you hear me or you haven't?
No, the last few seconds we didn't hear.
I was saying proximal tube occlusion with endometriosis, chances of pregnancy with reanastomosis is probably less than 30% or less than 20%.
Maybe the voice is not clear. So at the end of our discussion and presentation, Dr. Mohammed, do you have any home message for doctors about endometriosis?
I think so. The message is listen carefully to your patient, ask actively about the symptoms of endometriosis, train yourself for ultrasound, you see what you know. And I think with these two methods, we are going to shorten the period needed to diagnose endometriosis and to help them earlier before they reach as an advanced stage.
Dr. Fatma?
Agreed with Dr. Mohammed. I just want to add that again, full clinical interview with the patient, full examinations, because physicians and the new generations, they are away from proper clinical examination and going more with the imaging directly, forgetting the skills of how to examine and get the full information of patient with endometriosis and getting the positive clinical sign of endometriosis, adding with the imaging and getting the diagnosis, starting with hormonal therapy as a first line, preserving the surgery as a last resort, or the patient is not a candidate for hormonal therapy. And the last message is refer to the proper or the endometriosis specialist for doing this kind of surgery.
Dr. Ahmed? I'm sorry.
Yeah, going in for this kind of surgery, lacking the experience of doing and excision of this kind of disease will give the patient not the proper full surgical treatment.
Dr. Ahmed?
I want to extend the advice of Dr. Mohammed and say you can only see what you know, not just in ultrasound, but also in surgery. So get your eyes used to seeing different forms and different types of endometriosis, because you only can see and excise what you know.
Thank you. So before closing our ceremony, a big thank you to all our distinguished speakers. Dr. Fatma from Kuwait, thank you so much.
Thank you.
Dr. Mohammed from Germany, thank you so much.
Thank you, Professor Samah, for this invitation, and thanks for the all attendees. Okay.
Dr. Ahmed, thank you so much.
Thank you, sir. Thank you for the invitation. Such an honor.
It shouldn't be the first. It's the first time, but it will not be the last. Huge thank you to all people and doctors who attended and participated in this webinar. Without your presence, it would never have been successful. Thank you so much for the medical and technical team supported this webinar. Thanks, Professor Yasser Abu Talib, and thanks everybody. And before closing, a gentle reminder on our conference, because some people came late. So our conference will be on the 11th and 12th of December in Triumph Hotel, New Cairo, and we have some workshops around the conference. So on the 9th and 10th of December, we have a pelvic floor workshop, a total laparoscopic hysterectomy workshop, and a fetal medicine workshop. On the 13th of December, we have a colposcopy and oncology workshop and an assisted reproductive technique workshop. Thank you, everybody, and let's see you, inshallah, in the next webinar. Thank you so much.
Thank you, everyone, and have a nice evening. مساءكم سعيد إن شاء الله.
Thank
Thank
you
you.
for this informative lecture and for the company who are organizing this webinar. Thank you for the professors. This was nice to chat and change experience. And thanks at the end for the attendees for this informative webinar.